MRI scans, especially the ones which last longer than 1 hour. So there's clearly a disparity with the traditional definition of TIA based on the time-based less than 24-hour symptom duration definition. And the concept of TIA as we know it, ischemia without infarction. So clearly there will be many patients who are misclassified as TIAs who actually have underlying infarction. As a result of this new knowledge, we have moved away from the traditional time-based definition to a tissue-based definition of TIAs, where we define a TIA as a transient episode of neurological dysfunction without acute infarction. Clearly, there are issues here. The main problem is that it would require MRI imaging, and therefore it is not practical to be used in many parts of the world. But that is a hurdle that we need to look at how we can overcome. Next, let us look at how the evaluation of TIA has changed. Recent data has shown us that emergent evaluation and management can reduce the stroke risk by as much as 80%. This is what we would do now. The emergent evaluation would involve all this. Let us look at them in detail. And then there will be stratification of the risk of stroke after the TIA. TIA, we all know, is diagnosed purely on the symptoms, and we are looking for transient symptoms. Typically, the TIA symptoms would last less than 1 hour. And there are ways of classifying the likelihood of TIA based on the symptoms. If there are focal symptoms, especially motor, sensory, speech, and visual, TIAs are more likely. TIA is less likely with predominant brainstem symptoms such as vertigo and diplopia and ataxia. And TIAs are unlikely with non-focal symptoms like headache and transient loss of consciousness. We need to also keep in mind the TIA mimics, especially things like hypoglycemia, migraine aura, seizures, etc. Neuroimaging, as we discussed earlier, would be with diffusion-weighted MRI. We need to look at the risk factors, medical risk factors, and lifestyle risk factors. We'll be discussing them a little later. And we need to think of what is the likely etiology. And we would classify the etiology using the TOAST criteria. Is it a large artery disease? Is it a small artery disease? Cardiogenic embolism? Or whether there is another defined etiology. How do we do that? We look at the arteries, extracranial and intracranial. We look at the heart, the structure and the cardiac rhythm, and then we look at the blood. Next, we need to look at each patient with a view to finding out the stroke risk in them. How do we do that? We do that using a stroke risk score in each TIA patient. And the most widely used score is the ABCD2 score, where you use 5 parameters: age, blood pressure, clinical features, especially weakness and speech disturbance, symptom duration. The TIAs are very likely, as we discussed earlier, if the symptoms last more than 1 hour and the presence of diabetes. And using these criteria, we can categorize the risk into 3 main categories: low risk, moderate risk, and high risk. And if the score is less than 3, it's a 0 to 3, it's a low risk, and 6 to 7 is quite high. And what these data show is data from the TIA registry is the 1-year risk of stroke. And as we can clearly see, there is a very good correlation with the ABCD2 score. But there's a catch here. The new data has also shown us that about 20% of strokes following a TIA are in patients who were classified as low risk with ABCD2 score of less than 4. So therefore, we cannot wait and delay the evaluation and management of low-risk patients because they, like many others, can be at a high risk of strokes. So what is now recommended is that we should consider all TIAs as high risk, deserving urgent attention. As we noted earlier, we now know that urgent evaluation and treatment would reduce the risk of stroke after TIA by as much as 80%. And this urgent assessment is best done in a specialist service such as a dedicated TIA clinic with round-the-clock access 24 hours a day, 7 days a week. And these are two landmark studies, the EXPRESS study and the SOS-TIA study, both published in 2007, which have shown that the establishment of such rapid assessment clinics can lead to significant reductions in the stroke risk. Let's now move on to how management of TIA has changed. The current management would basically depend on antithrombotic treatment, antiplatelets or anticoagulants, and the risk factor management, medical risk factors and lifestyle risk factors. We said earlier that urgent assessment and treatment can reduce the stroke risk by as much as 80%. What we have also learned is that the benefits in the early stroke risk reduction with this emergency approach derives mainly from the use of antiplatelet agents. So firstly, in the acute stage, we need to use dual antiplatelet therapy. This data mainly for high-risk TIAs and also for minor strokes, using aspirin 300 milligrams loading dose and then 300 milligrams, and clopidogrel 300 milligrams loading dose, and then followed up with 75 milligrams. We need to start this within 24 hours and continue up to 3 weeks. The data for this come these two landmark trials, the CHANCE trial and the POINT trial, where the combination treatment was given for 90 days and led to significant reductions in the stroke risk. But there was an increase in bleeding with the POINT trial. But when we look at the pooled data from the CHANCE and the POINT, that the benefits far outweigh the risks, especially within the first 21 days. Combination therapy is better. There's a reduction of strokes by 30%. There's a reduction of all major ischemic events other than strokes, such as cardiac events and cardiovascular death by 30%. But there's a non-significant increase in bleeding, which is more or less persistent throughout time at a constant level. So clearly, there's a net benefit within the first 21 days, especially within the first 10 days, with the significant reduction of ischemic stroke risk. What do we do next? We need to give long-term antiplatelet therapy, and the guidelines will tell you that there are 3 options, either aspirin alone, clopidogrel alone, or a combination of aspirin and dipyridamole. But what we have learned is that aspirin is the most important antiplatelet treatment. There's nothing better than aspirin when it comes to early stroke risk reduction. Combination of aspirin and clopidogrel, there's no added benefit because there will be an excess bleeding risk. Aspirin and dipyridamole, there's new data that has shown us that can be beneficial, especially in preventing strokes after 12 weeks. Both total strokes and especially disabling and fatal ischemic strokes by up to about 36%. Does triple therapy work with aspirin and clopidogrel and dipyridamole? The TARDIS trial has shown us that it can be associated with excess of bleeding, so we don't recommend it. What this recent meta-analysis has shown is that aspirin is associated with large reductions in stroke risk, up to about 60% of recurrent ischemic stroke and about 70% of disabling or fatal ischemic stroke. And what it has also shown us is that the benefits in risk reduction are mainly within the first 6 weeks. But after 12 weeks, there is hardly any difference between aspirin and placebo. So the benefits are very little after 12 weeks. And that's where perhaps that the benefit of combination of aspirin and dipyridamole would come in, where the combination has been shown to be very beneficial after 12 weeks. The next thing we do is to look after the risk factors, medical risk factors. We need to manage hypertension, keep it less than 140/90 and 130/90 if there's diabetes or small vessel disease. We need to give them intensive statin therapy to reduce the LDL cholesterol levels to less than 70. We need to manage diabetes, consider oral anticoagulation when there's a cardiac source of embolism, warfarin or the newer oral anticoagulants, and refer for carotid endarterectomy or stenting when there's significant carotid artery stenosis. And we cannot forget about the importance of the lifestyle modification, looking after their diet, smoking, physical activity, weight reduction, and limiting alcohol intake. What we have done today, ladies and gentlemen, is to look at the changing face of TIA, and with the current knowledge, we know that the definition, evaluation, and management of TIA all have changed. So has this new approach led to any improvements in TIA outcomes? Yes, according to this systematic review, where they looked at the TIA outcomes over 4 decades. They divided this into 3 groups. Group A, before 99, where new guidelines recommended changes in medical and surgical management. 99 to 2007, where the 2 landmark publications we talked about with the establishment of rapid assessment clinics, and then after 2007 in Group C. And what we can clearly see is that there has been a significant stroke risk reduction following the introduction of the TIA guidelines in 1999. There's a clear reduction of stroke risk between Group A and B. What we also can see is that there has been hardly an improvement from Group B to Group C. So clearly, there's a lot more that we need to do. So ladies and gentlemen, I hope you would agree that TIAs are like volcanoes waiting to erupt as strokes. And early evaluation and management of TIAs can significantly reduce the risk of these strokes and reduce the risk of death and disability, the large craters in patients and their families.
Thank you, Dr. Ranawaka. Let me see the question. Oh no, no question from the audience. I'll ask a question. What's your strategy for patients with low ABCD2 score, below 4? Do you hospitalized every patient with low ABCD2 score?
Sorry, can you repeat the question again? Did you want to know what is the rate of low ABCD2 score TIAs? Is that right?
That's right.
Yes. So it's that's roughly about 20% in most international series. About 20% are in the low ABCD2 score. ABCD2 score less than 4 categories, 0 to 4 category, 0 to 3 or 0 to 4 category.
And if you when you treat TIA patients with aspirin, and then if aspirin treatment failed, what kind of medication do you use for the TIA patient?
Sorry,
don't you hear me?
Yeah. Can you repeat the question again?
Okay. If you have patient with aspirin failure, what kind of medication do you try?
If the patient is
fail to treat the TIA patient with aspirin?
Yes, we treat with aspirin. Patients with TIAs, we treat with aspirin and clopidogrel combination. We start with that and then follow up with aspirin.
Okay, thank you. We don't have any question from the audience. Thank you, Dr. Ranawaka.
Okay.
Yeah,
Thank you very much.
Good night.
Thank you. Good night.
Then I'm going to move the third lecture. The first speaker is Dr. Kanda Tanaka. Dr. Tanaka graduated from Osaka City University School of Medicine in 2009. Until 2017, he received training in internal medicine and neurology at Henley Hospital. From 2017 to the present, he has been working in the Department of Cerebrovascular Medicine at the National Cerebral and Cardiovascular Center, Japan. The title is Jesus Worker and Treatment, Dr. Tanaka, please.
Thank you, Chairperson. I'm very happy to have this opportunity. Here, I'd like to talk about embolic stroke of undetermined source, that is ESUS. I have no COI related to this presentation. In this lecture, I will focus on workup and management of ESUS, but we also need to touch on how ESUS comes. Embolic stroke of undetermined source, ESUS, represents patient